Did you know that diabetes can affect your skin? From dry skin and yeast infections to ugly fungus nails. Well, you're going to learn about these today with our guest dermatologist. And welcome to the Taking Control of Your Diabetes podcast. I'm Dr. Steve Edelman. I'm an endocrinologist at UCSD. I have type 1 diabetes, if you don't know that by now. And then I'm not here with my good friend and colleague, Jeremy Pettis, who also has type 1, who also works at UCSD. And we both do a lot of things here at Taking Control of Your Diabetes. Well, before I introduce our guest, I'd like to tell you a little bit about TCOID in 60 seconds or less, that we have a lot of great content. For example, we have a newsletter and we have an article that just came out on this exact topic, skin conditions associated with people with diabetes, tons of other content as well. We're on all the social media channels. Don't forget, we also have a live face-to-face conference for people with type 1 diabetes the second weekend in August. 600 people with type 1. You've never seen anything like it. So with that, I just want to say thank you for joining. And our guest is Tanya Nino. She is a ultimate dermatologist, referred to me from a good friend I went to medical school with, who's a dermatologist, and she used to work for and took over his position as chief. So tell our listeners and viewers about yourself a little bit.
Sure. I'm Tanya Nino. I'm a board-certified dermatologist, and I'm also boarded in micrographic dermatologic surgery. I am a department chair of the St. Joseph and St. Jude Heritage Medical Group Dermatology Department in Orange, California, and so happy to be here.
You're a native California.
I sure am.
Now, before we get into the specific skin issues that are associated with people with diabetes, why did you go into dermatology?
Well,
your skin looks awesome.
Oh, thank you. Well, everyone had teenage acne at some point, but the main thing that got me into dermatology was watching my dad suffer with psoriasis growing up. And when I was a kid, I would see my dad covered in psoriasis plaques, almost head to toe, and there weren't great treatments at that time. We didn't have biologics. All we had was cancer drugs like methotrexate. So that made me realize that dermatology can have a big impact on people's lives. And yeah, it's something external. Yeah. You can't hide it.
For people with diabetes, the skin conditions, there's common ones, and then there's ones that are more rare. And for our listeners and viewers, we're going to go through them, and as best you can to explain describe what they look like. So let's just go with the one that is the most common and probably affects a lot of people who do not have diabetes, is dry skin. And dry skin could lead to lots of other serious issues, as I understand it.
Yes, you're correct. So dry skin is one of the most common complaints and questions I get in my office. Patients want to know, why is my skin so dry? I'm always applying lotion. And it can particularly affect diabetics because of dysfunction in the adhesion proteins in the stratum corneum. So the proteins that allow the skin cells, the keratinocytes, to stick together. So when those proteins don't work as well, as we see in patients with diabetes, and combine that with the microvascular problems that we see in patients with diabetes, you can see dry skin.
Yeah, let me just interrupt that. You know, that first series of words you use to describe the cause of it, that's heavy duty stuff. Most of our listeners are lay people. We do have doctors, but that first string of words went way over my head. Say that again.
Okay. So our skin cells have like a glue that bonds them together. And when that glue is not functioning very well, the skin cells, don't stick together as well. And so then you have an impaired barrier and the skin can appear dry. And yep.
No, that's a great discussion. I need to put super glue on my skin.
So yeah, I mean, not so much super glue, but we talk a lot in dermatology about ointments and balms and topical things that you can put on that can restore the skin barrier when your own body is not doing a very good job of keeping it together.
Well, we're going to talk about therapies after we talk a little bit more about the dry skin. So the cause, there is a cause. It's not just one of these things that normal people get. It's because of diabetes. And I think for people that have microvascular disease like eye, kidney, and nerve disease, they're probably more prone to it as well. And I'm just guessing, Tanya, that if you have poor control, you're going to be on the dehydrated side. And does that contribute to dry skin at all?
So I don't really, people ask me that a lot. They'll say, I'm drinking enough water, I'm drinking plenty of fluids, but my skin is still dry. So I don't really know that systemic dehydration is gonna cause dryness, because there are people who hydrate really well and still have dry skin. So I don't know if it's a direct correlation.
But since I asked you, you're supposed to say that's a great thought, Doctor.
I'm sure it's part of it. I mean, I'm sure if you are yes, I'm sure, doctor, if you are dehydrated, yes, your skin is going to probably be dry, just like we see our lips are dry when we're dehydrated. So it's all part of it.
Yeah.
Yeah.
Well, what's the negative thing about having dry skin? What could that lead to that's not good?
Well,
other than just looking dry.
Yeah, other than just looking dry. So the big one, and especially in diabetics, is the barrier is not functional. So you are at higher risk for infection. So like a small cut or like a micro cut can allow bacteria or fungal organisms to get in and, cause an infection, cellulitis, an ulcer, an open sore, osteomyelitis. I'm just going down a long road of worse to worse to worse.
Yeah, no, that's important. And if your immune system is not working as well, maybe from diabetes, poor control, then you're more susceptible as well.
Correct.
What about itching and scratching? Because I know that when my skin gets dry, I could scratch it so much that it becomes raw.
Yep.
And I take a hot bath here and there to soak my knee. I had knee surgery, and my lower legs can get so itchy. Yeah. Right.
And that's another big complaint we see in dermatology is itch. So dry skin can be itchy. And so first of all, if you're scratching a lot, you're going to create those micro cuts that we talked about. Second of all, one thing I talk about a lot with my patients is that the itch causes you to scratch, which causes you to itch, which causes you to scratch. So the more you scratch, you're sort of training your nerves in your skin to make you feel itchy. And so a lot of the work I do with my patients who have chronic itch syndromes or like atopic dermatitis, lichen simplex, is helping them break the itch scratch cycle.
How do you do that?
Okay.
In a nutshell.
In a nutshell, well,
yeah, because I'm curious.
Yeah. So you talked about hot showers. Dermatologists are always against those hot showers, even though they feel good temporarily. They cause your skin to dry out more. So we like lukewarm water, mild soap, only soap in like the more important areas. You don't have to soap down all your skin because you're going to strip some of that barrier away.
What are those important areas? Well, the way you said that.
Your private parts. So
is that what you meant?
Yeah, that's what I meant.
Okay.
Yeah. So for some of my patients, I'll recommend topical analgesics, menthol, cooling creams and lotions. So I don't know if I'm allowed to say a brand, but sometimes
You can say a brand.
Yeah. So sometimes I'll say Icy Hot because it has the menthol and the lidocaine. So the menthol cools the skin, the lidocaine numbs the skin, but it doesn't have to be that brand. There are lots of topical.
Well, we can call them later to be a sponsor.
Menthol, yeah.
No, you can
Yeah.
say anything you like. That's how we work it here at TCOID.
Okay, so Sarna is another one. It has camphor and menthol. Or we have some topicals that have pramoxine, which is an analgesic. So just kind of training those nerves not to feel itch, but rather to feel cold, and then to sort of dull the nerve sensation with the anesthesia.
So it's really prevention is the obvious prevention is, control your diabetes as best you can, avoid super hot baths and showers as best you can. And my theory is if you do soak your knee in hot water, just put a ton of good lotion on.
Balm
Balm
and ointment, because Sorry to interrupt you.
No,
but
please interrupt, because lotion dries you out, right?
yes,
Right.
exactly. You took the words right out of my mouth. So when we look at in dermatology, we talk about the vehicles that the medicine is being delivered in. So we have, for example, starting with solution. That would have the highest alcohol content, then lotion, then cream, then ointment. And so ointment would have the least alcohol content. So that's why we like a lot of creams and ointments and balms more than lotions and solutions.
Balms is such an old-fashioned word.
Yeah.
But no, that's so important, because you go to a hotel room and there's usually a little thing of lotion, and that dries you out.
Yes.
So and that's important for people to know. I do remember that, and I use Aquaphor, and it's a little, I would say it's obviously thicker, stays on, and
Yeah.
but it's a good moisturizer.
Yeah.
Like you mentioned, there are other ones as well too.
Yeah. I like Aquaphor also. Yeah, I use it, and patients don't like to use it for their hands because it's greasy. So I'll have
Right.
patients just kind of like rub their hands together, the backs of their hands together to apply it, and I tell them, yes, you're going to be greasy for a few minutes, but it's the best moisturizer.
Yeah, and I've heard that, when you put it on your feet, you should avoid putting it between your toes, because that could lead to maceration. That's typical podiatrist.
Yeah, you don't want that over moisture where yes, you're correct, where the skin gets just too moist and macerated, and you get some skin breakdown and it can open up.
All right. Well, we covered the dry skin. I learned a bunch of stuff myself, so thank you for that. Now, does the dry skin and the susceptibility to infection, does that have anything to do with people who get yeast infections? And we can talk about yeast infections next.
Okay.
And it's good to explain the difference between yeast and fungus, if you can.
Okay, sure. So, well, yeast is a type of fungus. Yeah, so that's a good way of saying that. But we think a lot about Candida. Candida is a type of yeast, and we see candidal infections in diabetics, especially in places where the skin is occluded, meaning the skin is folded on itself, or there's excess moisture, excess sweat. So a lot of my patients will come in with rashes under the breasts, or in the groin folds, or under an abdominal fold, and it's usually red, macerated. The skin is breaking down, and patients don't know what to do. They don't know what to put on it.
And it's probably hard to treat if it is layers of skin on top of each other.
That's right.
So, yeah, and you guys can see the pictures in the YouTube and our newsletter, but it is quite pink and red. And I know it could be painful as well. So how do you prevent it, and how do you treat it?
Yeah. So, usually if a patient gets to by the time a patient gets to dermatology, they've already been to their primary doctor. So I usually see some of the worst and most resistant cases. So treatment is going to be with antifungal creams, pills if it's really bad. And then we tell patients to keep the area meticulously dry. So that can be using a blow dryer when you get out of the shower to kind of help dry off the skin, wearing loose-fitting cotton clothing, keeping yourself in a cool environment if when possible. Some patients will use like cotton cloths in those areas to absorb some of the moisture.
Just tuck it in there, kind of thing. What about the powder? Antifungal powder, if it keeps dry.
Yeah, so I like the powder more for prevention. So when I'm actively treating intertrigo, or this sort of candidal overgrowth in the folds, I don't like to prescribe the powder during the active treatment phase, because the powder and the cream will make a paste together. So cream when it's actively infected, and then powder for prevention. So I will sometimes prescribe nystatin powder. Sometimes it's not covered by insurance, or it's expensive. And then there are some over-the-counter powders available.
Yeah, and I could add that people who have, this is really related to people who have poor glycemic control. We know that for a fact.
Yeah, well said. Sometimes it's even a sign of diabetes before someone even knows they have diabetes.
Yeah. And what about when you get thrush, which is, I guess, the word to describe yeast in the back of the throat and the tongue. And I think I've seen that more with patients undergoing chemotherapy.
Immune suppression. That's right. Yeah. I don't see thrush very commonly. But yes, in the setting of immune suppression, it's something we see.
Yeah. For the listeners, I was telling Tanya that when I was a young kid, they said I had Edelman's disease because I had Candida in my groin area from being athletic, wearing bathing suits all day, and it was itchy.
Yeah.
So I would go around itching myself down there, and they called that Edelman's disease. But yeah, it's nice to have a disease named after you. You know that?
I will say that sometimes it's not always just Candida. Sometimes we see other dermatophytes. So, especially with like tinea cruris, which you described, like the jock itch, or tinea pedis. I'm probably getting ahead of us.
No, it's okay. That's our next topic.
Yeah. So sometimes it's not always just Candida. So we'll use a broad spectrum antifungal when it gets to be more of some of those other conditions.
Well, explain. Let's go right to tinea pedis, tinea manus. Describe what that means. I know it's a Latin phrase, but that is a form of fungus, correct?
That's correct. So,
like athlete's foot.
Like athlete's foot. Yeah. So we call those groups of fungi dermatophytes, meaning they love to live on the skin. So they're feeding off of the oils that our skin secretes and the keratinocytes that our skin is shedding. So dermatophytes dermatophytes can live on our feet. Sometimes we'll see overgrowth in between the toes, especially the fourth and fifth toe. Sometimes it'll be just like white, scaly, superficial patches, hands and feet.
With irregular borders?
Sometimes an irregular or advancing.
Just trying to show off my derm knowledge.
Yeah, an advance. So we talk about an advancing border, so where it looks like it's more active at the edges than in the center of the patch.
And so that's antifungal creams as well, correct?
That's correct. So we'll do an antifungal topical. We do have antifungal shampoos that sometimes I'll prescribe as a body wash in areas, because a lot of these, what I tell my patients is that a lot of these dermatophyte conditions they can recur. I believe that some people are just more susceptible to fungal infections, maybe because of the chemistry of their skin or the amount of oil they secrete. So, for example, tinea versicolor, we can treat it, but I tell patients this may recur. It may recur every summer when you're really sweaty. Same thing with tinea pedis, athlete's foot. It can come and go. So,
yeah, and I think it's a good segue over to, I think one of the things I hear the most complaints about is fungus nails. Big, thick, white, yellowish nails that no way you can cut yourself if you're older. And that is hard to get rid of as well.
Oh, yes. It's very hard to treat. I say it has a low cure rate and a high recurrence rate. And it's multifactorial, so it's not always just the fungus that's causing the nail to be abnormal. Sometimes it can be just chronic aging nails, chronic trauma to the nail plate, a lifetime of wearing shoes, having your toes rub against your shoes. Sometimes we have prior athletes where the nail plate doesn't adhere very well to the nail bed, and so it allows a secondary infection by the fungal organisms that are already hanging out in the area. I mean, these organisms are ubiquitous in our environment.
Yeah. Tanya, I've seen several scams on Instagram, kind of promoting some kind of crazy therapy to get rid of fungus nails because it bothers people and it looks bad.
Yeah.
I can tell you my story in a nutshell is that everyone in my family had it, and I had it as a young kid. So I think I felt all along that, certain individuals are more susceptible for it. I had it before I developed diabetes.
Yeah.
And I've been told that it's mostly a cosmetic problem on your feet. It could seed and cause tinea in your feet. But what happened was it somehow got to my thumbs, and that everyone sees your thumbs.
Yes.
And so that's when I took the oral griseofulvin.
Oh,
That's
yeah.
antifungal and
Sure.
systemic. And, doctors that don't know much, they said, oh, that's not good for your liver. But I think you're going to agree with me that it's fairly safe and it helps get rid of it. And it never
Yeah.
came back, too, my thumb.
Good for you. That's good. So in a diabetic, I wouldn't really even consider that a cosmetic problem because any fungal infection in a diabetic foot, as you know, can go on to become a much more serious infection. So,
Got it.
yes. So sometimes we do prescribe oral antifungals. The nail plate is very slow to grow, especially on the toes. So the treatment course is about 12 weeks of an oral antifungal it's called terbinafine. And
Is it safe?
it is safe. I will still check a liver function test 6 weeks in. It's safe depending on what other medications you take. So you would have to make sure there are no medication interactions. You have to make sure that you're metabolizing the medicine correctly, so it's not building up in your drug stream. So in your bloodstream rather. So it is safe depending on your medication interactions and and what other factors. So you want to talk about it with your doctor before having it, before taking it. But certainly, I will check liver function tests 6 weeks in, and the overwhelming majority are normal 6 weeks in. So then I'll continue another 6 weeks to finish out the course. But like I said, the cure rate is low, the recurrence rate is high, especially for toenail fungus.
Yeah. And when I said cosmetic, because people don't like the way it looks, and I will not wear like open-toed sandals.
Mm-hmm.
I wear sandals where they cover it because it's embarrassing.
I hear
for
you.
me.
Yeah, I hear you.
So, but
Yeah.
the thumbs was really bad,
Of course.
and so that was good. So, people with diabetes are very susceptible to getting these big, thick fungus nails, and I would say for anybody with neuropathy, see a good podiatrist where they can cut those thick nails. Don't try to cut them yourself.
Absolutely.
Grind them down with a grinder and get someone that knows what they're doing.
Mm-hmm.
So that's important. Okay, well, let's go to some conditions that may not be as common, but I think important. There's a condition called acanthosis nigricans, and we'll put a picture of that up, and maybe you can describe the way it looks, and we can talk about it because that's a condition associated with insulin resistance, which is some of the basic causes of type 2 diabetes. So I can jump in there with you when you get to that.
Sure. I get this question a lot in my office, even with obesity in children. Parents will bring their children in. They'll say, my son's neck looks dirty. I scrub it. It won't come off. It always looks dirty. Or young ladies with discoloration in the underarms. Patients are asking for bleaching creams and lightening creams, and what can we do? And acanthosis nigricans is what I just described, these velvety, hyperpigmented patches in areas where the skin is folded. So like the neck where you can have a flexural areas, or under the arms, and sometimes in the groin folds as well. And it's caused by a overproliferation of keratinocytes. So that's why bleaching creams don't work very well, because bleaching creams target melanocytes and melanin production. But with acanthosis nigricans, the pathology is more the keratinocyte overgrowth. So the skin cells are kind of overgrowing and piling on each other, and then you get that buildup of skin.
Wow. One thing I'm learning on this podcast is there's a lot of different types of skin cells. It's not just like skin cells. Am I right in saying that the only way to treat it, or if there is a way, is to reduce insulin resistance, there really is no treatment? You have to sort of just understand that it's there.
No, it's exactly what you said, is improving your glycemic control and weight loss. And so sometimes we have to have these difficult conversations with patients like, hey, I think this is insulin resistance. And patients will say, well, I don't have diabetes, or or sometimes I'll have to say, well, this is also associated with obesity. We need to consider weight loss. And that's one of the best ways to correct it. Of course, we always will offer options to patients. So when I walked in today, you mentioned amlactin or lachydrin, you said. Yeah. So lotions and creams that are keratolytic, meaning urea is one, ammonium lactate is one. So these alpha hydroxy acids that sort of dissolve that buildup of keratin can be helpful. They're only as good as the frequency that you apply them to your skin.
Yeah.
But that's what we recommend over bleaching creams.
Yeah, I think it was important we cover that one because someone may have it and they just don't understand why they have that discoloration. Okay, well, let's go to a condition called diabetic dermopathy. And please.
Okay, so diabetic dermopathy is actually one of the most common diabetic dermatoses, and it's characterized by hyperpigmented patches, usually most commonly on the shins. So these sort of oval, hyperpigmented, flat, and sometimes a little bit indented patches on the shins of diabetics.
Now, what causes that? Someone told me once it's from trauma, like when you put your dishwasher door down, you hit it about the level of your shins, and then you end up with these marks there. No, is it started by trauma?
So yes,
minor.
Yeah. So when you look at the literature, it's often associated with trauma. So the way I break it down for patients is it's kind of like your skin is not healing very well. You're getting inflammation because of when your body was trying to heal the trauma, you had a little bit of hemosiderin breakdown from the red blood cells, and it leaves sort of a stain in your skin. So, it takes months or years to fade, and sometimes it never goes away completely.
So that's a cosmetic problem.
Yes. Yeah.
Come on.
Yeah. You can. I guess you can.
It just doesn't look good.
It
represents an abnormality, but I like I've never heard that before about the hemosiderin, which is a color of light red.
Kind of like these orange brown patches that are the residual when you've had an area of inflammation, or even we see it even after bruising or with microvascular problems where the red blood cells just kind of like die and spit up their hemosiderin, and it stays like a stain in your skin.
Okay. Now, you wanted to talk about skin tags, and I'd never associated skin tags with people with diabetes, but please, you got the mic.
Oh, yeah. Well, I added it to your list only because it's just so common in patients with insulin resistance, and we get these complaints every day because they protrude, they itch, they rub on clothing, they catch on jewelry. And so patients hate their skin tags. And it's another one of those difficult conversations we have to have sometimes, which is like, hey, this could be related to insulin resistance and diabetes. And so they can get inflamed, they can get irritated, and patients want to get rid of their tags. So
how do you get rid of their tags?
So my favorite way to remove the skin tag, the best way I think, is to snip them off with little scissor snipping.
No anesthesia?
Yeah, with a little bit of anesthesia. So we put some antiseptic on the skin. We put a little drop of anesthetic under each tag, and then we snip them because then they're gone. But they can be frozen with liquid nitrogen, in which case they would just scab up and blister and then fall off.
I see.
Later.
You spray them with that little gun?
Yes.
That you charge a lot for? All right. Well, let's do one more condition.
Okay.
And I don't think it's as common anymore, but it's called, NLD, necrobiosis lipoidica diabeticorum. How's that?
Good. And good pronunciation.
It's probably good for any medical student taking the boards because, they always put rare things on the boards. Yeah. Yeah, maybe you can explain that.
That's good. So NLD, necrobiosis lipoidica, we see it over the shins of diabetics. And sometimes these patients will come to us from wound care clinics where the wound care specialist just throws their hands in the air and they just don't know why this wound is not healing. And that's when they start referring to vascular or dermatology. But patients will get these orange tan papules that coalesce into plaques, and the collagen is abnormal in those areas. And so what happens is the skin can break down. Sometimes the areas can ulcerate, and it's also accompanied with a lot of inflammation.
Yeah. And do you see it very often?
I don't see it very often. Maybe in the last year, I have one type 1 diabetic patient who developed NLD. And then over the years, maybe one every couple years will come in with it.
Well, you just said something super important. I believe it's the only dermatologic condition that is specifically associated with type 1 diabetes, where acanthosis is more type 2. So NLD, I think, thank goodness, is not occurring as much as before. And there's all kinds of treatments to get rid of the ulcers, but thank goodness it's not as common.
Right. Not as common and treatable. So for my one patient that I had this year, we used topical steroids, and that was able to get it under control.
Yeah, and that hopefully doesn't mess up the blood sugars that much.
Yeah, I agree. Yeah, it depends. If you're applying over a small body surface area, you're going to get less systemic absorption and less disruption of your blood sugar.
All right. Well, gosh, that was a great podcast. I learned so much. And I think our listeners will have also learned a lot. And let everyone know that we do have a blog where they can ask questions at any time. I typically answer them. So I might be emailing you for regarding some of the questions that I'm not going to give them an answer that I'm not 100% sure about. Well, thank you for joining us.
You're welcome.
And you are now our honorary dermatologist at Taking Control of Your Diabetes. And thanks for coming down to our studio today.
Thanks for having me.